Hi, everyone. Thank you for standing by and welcome. Today's webinar is brought to you by the Florida Head Start Association and the Florida chapter of the American Academy of Pediatrics. This session is titled Trauma-Informed Care in the COVID-19 Era. Before we begin, I have a few housekeeping announcements for you. All participants are in listen-only mode. There is a slide presentation being shown on the screen. Attendees, please use the chat box to let us know if you're having any technical issues or if you have any questions for the presenters. We will be addressing most of the questions at the end of the webinar. Afterwards, you will be automatically directed to a feedback survey, which will include a link to the certificate and a link to the PDF handouts. Please download those files before submitting your responses to the survey. And lastly, this webinar is being recorded. Now, moving on to the main event, the session will be presented by Drs. Jennifer Takagishi, Susan Aronson, and Elaine Donahue. Thank you so much for joining us today. Dr. Takagishi, I will turn it over to you.
Thank you all for joining us this afternoon and taking time out of your busy day to join our webinar. Our speakers today, as were mentioned, I am Dr. Jennifer Takagishi, Professor of Pediatrics at the University of South Florida. I am also the Early Childhood Champion for Florida, and my role is to connect early childhood systems together with the Florida chapter of the American Academy of Pediatrics. Our second speaker will be Dr. Susan Aronson, retired clinical professor of pediatrics from the University of Pennsylvania, and our final speaker is Dr. Elaine Donahue, clinical professor of pediatrics at the University of South Florida. Both Drs. Aronson and Donahue have been heavily involved with writing books on health and safety performance standards and managing infectious diseases in child care settings. We will each present a section of the webinar, and as mentioned before, we'll save time at the end for questions, and we'll be monitoring the chat room as well. So our objectives today are on your slide. We already know that trauma has a major impact upon us, and COVID-19 has added an additional level to this. Today, we'll be defining trauma, its impact on young children, adverse childhood events and trauma-informed care, how trauma may be associated with challenging behaviors and management strategies to help. We will discuss resilience building for children and staff and provide some examples of how you as early childhood educators can help children, families, and other staff cope with trauma. So I wanted to start with two definitions of childhood trauma. The first from the National Institute of Mental Health and the other from the Office of Head Start. They both emphasize an event or events that are emotionally painful or distressful and overwhelm a person's ability to cope with the situation. What is just as important is that the result of being overwhelmed can lead to long-term mental and physical consequences. Our goal is to learn what we can do in early childhood to try to mitigate these effects. So adverse childhood experiences, also known as ACEs, are traumatic events that occur in childhood and can lead to toxic stress that can change brain development and affect how the body responds to stress. These ACEs were developed from research completed at Kaiser Permanente in California, where they studied 17,000 predominantly white men and women, middle and upper class, college educated, and insured, and asked them if they had experienced any of the 10 circumstances while they were growing up. They found that the more of these difficult circumstances a person had experienced, the more likely they were to have long-term physical and or mental health consequences that could include substance use, diabetes, heart disease, depression, and suicidal ideation. So this is a list of the original ACEs that were studied by Ferletti and his team at Kaiser. They include several types of both abuse and neglect, as well as domestic violence, substance use by family members, and incarceration of family members. 1 point was awarded for each of these ACEs. More recently, several other adverse childhood experiences have been proposed, and some have also included poverty as an additional potential ACE. This is relevant to all of us, as many of the children and families we care for in early childhood centers and Head Start have been exposed to one or several of these circumstances, and their ACE scores may be pretty high. So, how do we know if a child has been exposed to trauma? Children are not going to walk up to us and tell us about their home lives or what they've witnessed or say, I have trauma. Instead, they may show symptoms that suggest exposure to trauma. Some of these symptoms were put into an acronym that I find very helpful, FRAYED, F-R-A-Y-E-D, such as when you're at the end of your rope. The letters suggest fits or tempers, having difficulty regulating your emotions, having trouble attaching to others, yelling, having difficulty regulating your emotions, having trouble attaching to others, and feeling defeated or hopeless. So, what do we do when we see a child displaying signs of trauma? We want to help them build a cloak of resiliency. We will define resilience in more detail later in this webinar, but there's another acronym that can be useful to help us remember how to build resistance, and it's THREADS, T-H-R-E-A-D-S, which stands for Supporting a Thinking and Learning Brain, Inspiring Hope, Assisting Children to Regulate or Control Their Emotions, Build Efficacy, Helping them with attachment to nurturing adults, supporting their mastery of skills, and making them feel connected to others. So in contrast, when children have had traumatic events happen to them, and I do want to emphasize that these events happen to them and are not caused by them, that these threads can be ripped apart and lead to their learning brain shutting down, their hopefulness shutting down, an inability to control their impulses, their ability to react appropriately to situations lost, the ability to attach difficult when toxic stress is mounting, learning new skills can be shut down, and their sense of social connectedness broken into feeling as if they are alone with their threat. By taking a trauma-informed approach, we can try to support children and families as they deal with trauma. And the mnemonic that can help us remember how to do this is the 4 R's. The first is the realization of the impact of trauma, and that there is a means to recovery, and that's a really important first step. We also need to recognize trauma signs and symptoms like we discussed earlier, such as fearfulness, hopelessness, difficulty learning or regulating emotions, or having attachment issues. We also need to respond appropriately. This means that we may not be able to fix every aspect of the system at once, but we need to do as much as we can within our own systems and help our families and children connect with other systems that can support them. And fourth, being mindful that we can re-traumatize individuals if we do not decrease unnecessary triggers. Now, some of this is much more difficult with COVID, as some of our traditional support measures, such as routines, hugs, smiles, etc., will be challenged and will need to change, but the more we can do to remove triggers, the better. I really love this quote. The more healthy relationships a child has, the more likely he will be to recover from trauma and thrive. Relationships are the agents of change, and the most powerful therapy is human love. This quote's a reminder of how early educators are so important in helping children and families recover from trauma. And more importantly, I would add that they decrease the impact trauma may have in the first place. Relationships are key to this, and we will talk more about safe, supportive, nurturing relationships later in this webinar. So we're now going to transition to Dr. Susan Aronson, who will discuss how trauma can lead to challenging behaviors and how early educators can manage them. Some of these challenging behaviors were around before COVID, but COVID has exacerbated some of these behaviors and escalated the need for management in a caring and supportive manner. Dr. Aronson, you can now take control.
A nice introduction. Thank you, Jennifer. I would like to respond to one of these prompts. How trauma can lead to challenging behaviors has really been outlined by Jennifer's presentation. What we want to grasp is that notion that challenging behavior in children is more likely to be shown by young people and even adults. We can apply this to adults like staff members and colleagues who've been exposed to trauma more than average for their group. That's an explanation that is useful to remember that what the definition really is and what the cause is summarized. COVID-19 is causing physical and mental health trauma for children and adults, and there is a priority for prevention of spread of infection on what is sometimes used, we're using acronyms here, as the 3 W's. This was listed by Tom Friedman, who physician and former director of the Centers for Disease Control and Prevention, the 3 W's. So I will tell you about the 3 W's in a moment, but I want to point out to you that in just this week's issue of Pediatrics, they reported on a survey of 1,000 parents who were asked about how their experience was being affected by COVID, and 27% of them said that their mental health has worsened, and half of that 27% said that they had lost their access to their child care. And 14% of that 1,000 families who were surveyed said that their children's behavior had become more affected and worsened by the COVID virus. So I'm trying to change the slide. I need a little help here, please. Oh, still not changed. There we go. So one of the 3 W's is wearing a mask. The second is wash your hands often, and the third is watch for the appropriate physical separation between people. So let's just start with the first W, wearing masks. Wearing masks is a difficult request for young children, and it is recommended for children who are at least older than 2 years of age, where it is considered to be safe. The CDC and the Academy of Pediatrics recommend wearing cloth masks for all adults and all children over 2 years of age, with a little quotation, when feasible. So you know, that's a caveat, that we'll have an opportunity to really work on the skill development. It is a teachable routine, and really it's most important when the child is away from home and not with the consistent family network that allows them to not have to be so as concerned about protecting the people who are around them. Because what masks really do is to prevent the spread of COVID-19 virus by keeping the germs that the virus that caused COVID from getting out to other people. And the corollary of that is that other people need to wear their masks to prevent the transmission of the virus to the people around them. So it's about doing for others around you and being protected, and you cannot know whether or not any particular individual is a risk to you, because people who have no symptoms at all, in fact, can spread the COVID virus. So this is doing a good thing for other people and making sure other people are doing a good thing to you. And a tool for making this work is to identify people who are wearing their masks, including adults and service people and other people, and make a practice of saying, thank you for wearing a mask, because the thank you lets them know that you have recognized their contribution to keeping you safe. The second W, if we can change to the next slide, let me just see if I can make it happen. Oh, I'm going to need some help. The second W is frequent hand washing. Now, hand washing has been around for quite a long time as a means of restricting transfer of infection from one person to another. And it has been shown, and it has been shown for COVID too, that it does reduce the risk of spread of disease. Children and staff should wash their hands at many times during the day. We want to try to learn and use those times. So the first one is when they arrive at the child care program, they should wash their hands, and whoever comes with them should wash their hands before and doing anything related to food, drink, playing with water used by more than one person, toothbrushing, after toileting, handling any body fluid. You can see the list gets quite long. And the important measure of whether or not appropriate amount of time and rubbing of the skin is being done with soapy water is the 20 seconds rule. 20 seconds has been measured to be most effective to remove the layer of body oil and the holding of virus particles on moisture that is in the air. 20 seconds works best. And how do we 20 seconds on children? Well, you can teach counting at the same time that you're getting the proper amount of rubbing. So you can go bubble 1, bubble 2, bubble 3. By the time you've said the bubble plus the number, it is a second. And so even though children may not easily get up to 60 to count up to the 20 seconds and learn their counting. The adult who's with them can do that, so that when they get to the 20 seconds, you say, "And you're clean." I kind of like the songs that help to measure the 20 seconds, but again, we have to think about making sure that it's gentle singing, because loud, boisterous singing may actually put more particles into the air. But I kind of like a song that goes with "Row, Row Your Boat" and the melody, and you sing it twice. There are a number of different kinds of words that go to the "Row, Row, Row Your Boat" melody, but the one that I choose and teach to the children around me, including my grandchildren, is "Wash, wash, wash your hands, play this handy game. Rub and scrub and scrub and rub, germs go down the drain. Yay! Wash, wash, wash," and so forth. Do it a second time. You can also do the ABC song all the way through once. That's also about 20 seconds. And the way to wash your hands has been put into videos and is available in posters that the Centers for Disease Control has available. And you might want to just go on the cdc.gov website and look for those posters. Some of them are appropriate for very young children, some for staff, but there are a large number of different ones. Some of the states have made their own posters as well. California and North Carolina have posters that they've arranged to have done. So search the web for the Caring for Our Children standard. It's 3.2.2.1, 3.2.2.1 in Caring for Our Children, the National Health and Safety Performance Standards, and it gives a list of when and how hand washing should be done in child care. So that's the second. Wash your hands is the second W. The third one is related to maintaining your physical distance. And it's not social distancing. Somehow that got it put in there inappropriately in the beginning, that it was going to be something that would be influencing your coming together in groups. And that, I guess, is how it happened. But it's really about physical distancing. Staying 3 to 6 feet apart is the physical distance for traveling of airborne droplets that spread the COVID-19 virus. If you have very young children, to show them what 3 feet might be, is have arms out at either side of their bodies, and they are now, if their fingertips would just barely touch the person on one side, on the other side should barely touch also. That is about 3 feet in a young child. In an adult, it's 6 foot separation can be measured with this broad arm approach as well. But social engagement is important. The fact that you use physical distancing to keep the virus from traveling to you from somebody who might be infected and might not even know they're infected is just a wonderful way to separate the risk, reduce the risk. But social engagement is important. We don't want to sacrifice that just because we have this great concern. And in fact, it's a cause of trauma that we have reduced the amount of aggregation, of getting together. The recommended routines in terms of the distancing are very difficult for family members and staff to follow. Family members who are available to drop off and pick up children are often among the vulnerable group who may very well be engaged to be the drop-off and pick-up people. And the staff is also handicapped by this distancing in terms of meeting the socio-emotional needs of the individual children, especially during the drop-off and pick-up time. What we need to do is to try to protect those who are at greater risk, like those who are over 60 or who stay home with an underlying medical condition, and so get the job of pick-up and drop-off. We need to make sure that at those times, if it's possible to have the same person do the drop-off and pick-up from the family, and if it's possible to organize the staff drop-off and pick-up person who makes the transition to make sure that that person appropriately recognizes the physical distancing requirement, and also that that person is the person who receives, or there's a designated person who receives concerns and reports from the family about how the child was during the night and time that the child was at home, and in turn at pickup time gives information about how the child was during the day to the pickup person to make sure that the family gets to have that information. Avoiding a large number of people gathering outside a facility when you have all this going on and trying to be careful about who's doing what and transferring the information can be a really challenging problem. And we suggest, but it's difficult, you got to just try your best to assign a consistent time and the consistent people for the in and out of pickup and drop off. The escort for each child should be and urged to deliver information to and from the child care and the family, and especially make sure that whoever provides the most care within the family gets that information. And you may find that if you have important information that should be transmitted using the phone, the less technically sophisticated email, but the phone, so that you can have some conversation, communication in real time about what's going on with the child. It is difficult to stagger arrivals and departures and hard for working parents to do that, but and every effort should be made to do it, because it's important to have the communication, especially when you're beginning to have challenging behavior. You want to get a consistent plan for how it's going to be handled both at home and at the program. Let me give you some examples of what's happened, though. If we can just switch to the next slide. This is how COVID-19 has affected management of challenging behavior. Some examples. Before COVID-19, consistency was more achievable than it is now. There are now, since COVID-19, there are lots of new rules and cues and developmentally challenging routines. Before COVID, we had developmentally appropriate expectations for how the child was going should be able to behave. Now we have to accommodate the stresses that children are experiencing and families are experiencing. And so we have all these extra routines. The hand washing needs to be more and better from appropriate time. And children over 2 need to be taught how to wear their masks to protect them. And we mentioned the issue of hugs. I think we have to remember that touching is a very important way to make children feel comforted, and to accomplish it. Before COVID-19, hugs were okay, and you didn't need any special personal protective equipment. But now there are restrictions on comforting children and colleagues and there is an important need to provide trauma-informed care with these and approach it with these possible remedies. One is that for infants who need to be held while fed, and for infants and toddlers who need to be comforted on a physical basis more often than others, that one-to-one time between the staff and the child can be facilitated by having a clean smock assigned to the specific child, but the smock is for the adult staff person to wear when comforting and holding and feeding a child who is needing to be assisted in eating. You want to plan stable, consistent routines with small groups, and this is sometimes very difficult economically for a program to organize so that they have enough staff for the children that they have and that they don't have to make smaller groups that are not economically viable for the program to maintain. But in any event, the kinds of rules and changes that are needed are substantial. And it's important to try to limit the numbers of things that you are requiring of the families and of the staff, with the understanding that the numbers of things that have been laid on quickly over the last year really are traumatic, and doing too much at once is going to be very difficult. The goal should be to decrease stress when you can, and try to identify the challenging behaviors that are important to change. And for those, we're going to talk about giving positive attention to those who need to change their behavior as because of its level of importance. And the mechanism for doing that change has to do with decreasing the stress, where you can figure out from the trauma that is being experienced what that stress is and try to reduce it, and then begin to give positive attention to children who are doing the desired behavior you want and reinforce it with great regularity. We'll talk about that a little bit now when we go to discussing how to approach challenging behavior. As the developmental behavioral experts say, a child who can succeed will succeed unless the child is being asked to do something that's too hard. And this can be applied to adults as well. The staff may be able to succeed if they're not being asked to do something that is too hard for them to do. So assessing what is being required and zeroing in on the things which are important. If the child is showing you a behavior that really you think it's unsafe, it needs to be changed, it needs to have priority, then you need to think about and talk with your colleagues about what it is that is most important, so that you select out no more than 4 behaviors that you want to improve, and use those behaviors as the target of your positive reinforcement, and engage the families in doing the appropriate reinforcement of the same behavior at home. So encourage a lot of interaction between staff and parents about what it is, which behaviors you think are most important to change. Try to ignore the others until you satisfactorily change the situation that is difficult, and get the child to be able to learn to succeed with the ones that are most important. Facilitating the child's successful interaction with peers will help to bring more positive experience to the child. If you have a negative experience, like "don't do that," "I don't like that," "I don't," that tends to undermine the impact of the positive reinforcement that you're giving at other times. You don't want to bribe to thinking you're going to get success, because bribes really, if you fail to meet the desired behavior, the bribe is just nothing but a disappointment, and you don't learn very much from it. So try very much to look at positive interactions uh, and positive attention. Children want attention, and they want attention positive attention makes them much more likely to want to repeat the behavior that got the positive response. The behaviorists, the developmental behavioral pediatricians recommend looking for an opportunity to give a very short positive response, about 3, 4, or 5 times at most each hour. Children learn by imitating your behaviors, and they repeat these behaviors when they get the attention for them. So you will hear this recommendation repeatedly from me and from others, is that you need to try your best to give the positive attention that makes behavior change. They play what they see other people do. So when you're thinking about how you're going to induce children to do their good job on hand washing, be sure that the staff are demonstrating, role modeling proper hand washing. And that should mean that you will be deliberately calling attention to the positive behaviors when you're modeling them, and also giving short, very short, I like the way you wear your mask is a good example, short levels of approval and attention. The next slide. The tools for successful behavior management are, as I've outlined, focused largely on helping children learn to do what is possible for them to do, and to involve them in environments and getting interaction with their around them that will make them want to behave the way you are looking for them to behave. As far as the environment is concerned, the spaces should be adjusted so that they actually induce the kind of behavior you want in them. So spaces for large muscle activity would be a lot of time spent outdoors, but also there need to be places when you can't go outdoors where there can be some large muscle activities. You have small group activities and individual activities, and you can use your furniture to make activity centers, arranging the furniture to discourage running so that it's difficult to get up at some speed, and also offer clues for places to do desired activities. So if you want to have a quiet, get yourself back together again corner with books, that speaks to what is good in that environment. The systematic use of adult attention I keep coming back to because it is a key measure for changing behavior. Don't give children attention for misbehavior, because the need for attention is so great in early childhood that children will misbehave if that's what gets your attention. So try very hard to ignore the misbehavior. You might give some instruction at some time separate from the behavior about what kind of walking feet we use when we're inside, those kinds of things, and talking with the children about the rules that make sense to them. And to the extent that you can, increase the predictability of the scheduled day so that the children can learn the routine and be more cooperative because they are participating in implementing something they can anticipate. Try to limit the classroom rules to no more than 5. That number is even stretching it for what children might be expected to do, and encourage their children's participation in the rules, in making rules that they think make sense, and then keep them simple, and maybe remember them in the morning gathering. Today we're going to work on whatever the rule is that you're working on. Perhaps it's on good hand washing today. And when you are offering choices to children, be sure that you can offer them only those which you're willing to accept their choice of either one. So, you can say, would you like to read in a book area, or would you like to play with the Play-Doh? If both those things are okay with you, then whatever they choose, try to honor it. So the tools for successful behavior do not include pushing children into timeout. I want to be very clear that timeout is really for children to regain their self-control as a positive. If you seem to be upset and stressed, let's give you some time to get yourself together, and then you come back in to join us when you're feeling better. And if the child doesn't want to do that, we'll say, I think it would be helpful, but we'll try to work on what you can, try to have these okay choices. So the other tools to manage challenging behavior, using visual clues is for expected behavior is helpful. So in a corner where book reading is expected, so you can put some books up around that are the appropriate weight and size and type, and that gives a clue to what that part of the environment is supposed to do. And also, if you have the schedule of the day made up of pictures of the things that are planned, and then affirm that the importance of those that activity that's in the picture, that will eventually, not too long actually, the child will begin to learn to anticipate what is expected. We talked about large muscle activities. That is a great way to let stress off. I think both staff and families appreciate that opportunity when it's available to them. So hopping, doing whatever is developmentally appropriate. Crawling on a mat is one. Being outside on mats gives a child who's not yet ambulatory a chance to have the outdoor experience. And teaching children the words for feeling sad. You seem sad. Or I feel sad because the ball had a hole in it, and I feel sad. Another word that is not on this list, sad, mad, happy, glad, is angry. And that's a very important word for someone who has experienced trauma and had to reduce the opportunities to do the things you want to do. You can say, I feel angry about that, and that's a reasonably good thing. Again, remember to be, as often as you can, use a brief positive comment when the child seems to be able to accept it. I see that, and you can say, I see that you're feeling better now, and you're not so angry. And keep those that feedback as short as possible, so that you don't lose the attention and control. You might want to look at the way that many of these stores have directed the people who are their customers by putting tape on the floor indicating what direction to move in to not run into other people, and spacing, the 3 to 6 foot spacing. That can be practiced in the child care room by having the children line up on the tape, and that shows them where the distance separation is. Inclusion, one of the things that really is a very harsh way of dealing with challenging behavior. It is often not necessary for behavior control if the family and the staff get together on what behavior they're going to reward, and with a positive comment, or it can be a star next to the child's name. That you got. I'll give you a star for today's help with moving the books for us. It can be just something as simple as that, but not a bribe. Not a, if you do this, then you'll get that. But an after the behavior, recognition of the behavior. Exclusion for illness with COVID is being ramped up as more uh, rigid than before. Before, we suggested that exclusion from ordinary upper respiratory infections was not necessary and often ineffective because the common upper respiratory infection is contagious for several days before symptoms appear. And in fact, that seems to be true of COVID-19 also, that the child may look perfectly well and be coming down in 2 or 3 days with symptoms of temperature of 100 plus, where the temperature for exclusion has been made more stringent than it was before COVID-19. And so we're taking more temperatures and looking at anything that's over 100.4 as a reason for excluding. But if for the ordinary cold, the runny nose, you've already been exposed, and if the child can participate in the activity of the program for that day, and you have enough staff to provide care for the mildly ill child without reducing the appropriate care for other children in the group, then except for exclusion for specific conditions that are named in the Caring for Our Children standards and in the Management of Infectious Diseases in Child Care and Schools book, which is available from the Academy of Pediatrics. Those specific conditions are, for example, diarrhea, that is more than 2 episodes of watery stool over and above what the child normally has in that same period of time. That's the definition of an excludable status of diarrhea. But for the most part, the very common runny nose really does not need exclusion. But again, you're looking at the level of severity of the infectious symptoms, and parents who are struggling to cope with all the stresses of keeping their job or getting a job will not appreciate having an exclusion that occurs just because they have a very limited finding. So let's just review now. We're one ahead here. Let's go back one slide, please. Just to review before we look at them. Okay. To review what the tools are for managing challenging behavior. I want to briefly offer praise for desired behavior, and I mentioned before, as often as 4 to 5 times per hour, especially when you're introducing this desired behavior. Ignore mildly inappropriate behavior, because the more attention you give it, the more you'll get it. And then continue the positive response to the appropriate behavior. And if it is something they really can do, you can't be asking something that they can't do, but you need to persist, even if they seem to be going on or even increasing the inappropriate behavior in a testing fashion for 2 to 4 weeks. Give it 2 to 4 weeks before they might be stubbornly not giving up that behavior, and you're just using positive reinforcement. But usually children will go for the positive behavior, and as long as there's not something that they can't do. And try to seek the same approach at home, in childcare and other settings, and get a collaboration working to address the particular behavior you're trying to change. And if you can, limit the numbers of behavior that you're trying to change to 1 to 2 and at most to 5. So what if misbehavior still occurs? That's a time to check. Are you giving the 5 times the attention for desired versus the inappropriate behavior? Are the rules clear and consistently reinforced? Are the expectations too high or too low? Too low means that you're not treating them and using their desire to model on your behavior. And you might want to look at whether you can raise that threshold a bit. And check to see if the staff and family are catching and rewarding the good behavior that you want to. And as I indicated, stars on a chart are okay, but best to just make it a short verbal comment and no bribing. If you have done all this and things just are not getting any better, you can't find a way to get adoption of the desired behavior, then it's time to refer to a mental health consultant or social service agency. There may be that there's so much stress in the family life that this is coming out in the child's behavior. And we have to hope that we can increase the support for the family and for the staff to have a positive approach and planned approach to improving the challenging behavior. And if you have been able to do this, then you're beginning on the resilience. And now Dr. Donahue is going to talk about, I can go to the next slide, thank you, about resilience, and I'll turn the microphone over to her.
Thank you, Dr. Aronson. I'd like to build on that idea of reinforcing positive behaviors and talk about how we can build resilience both in children and in ourselves. The definition of resilience that we had developed is the capacity to recover mentally and emotionally to baseline after a stressful experience. And that is true for both children and adults. So in this section, we're going to talk about resilience, self-care, and then we're going to use these concepts with a few examples that we have. Oops, sorry. So the research on resilience in children is still evolving, and we're still learning about it. But one of the most consistent factors that has been identified is the presence of a caring adult in the life of the child. So that caring adult provides a safe, stable, nurturing environment. And as early childhood educators, you are perfectly positioned to become that person and to help build resilience in children. You can also role model self-regulation because the research has shown that our response to the stressors can be more important as the stressor than the stressor itself. So if we're having a difficult day, say we spilled paint on ourselves and we're understandably upset, we can say, oh, I'm so upset about spilling paint on my shirt. I'm having a hard time. Can you guys help me take some deep breaths so I can get back to myself? And that way we show children how we practice self-regulation. The other factors associated with resilience in children are the children's ability to learn those lessons and actually begin to regulate themselves. And that can depend a lot on their social emotional development, their physical development, and on their problem solving abilities. So those are things that we want to work on. And that transitions to talking about building resilience in ourselves. So we all know that if our computer gets stuck, it's helpful to turn it off and on again to reboot it. So we need to do the same thing to ourselves. We need to reboot. We need to get ourselves back to functioning properly. The old saying that you can't pour water from an empty pitcher is very true. We need to fill ourselves up, recharge our batteries, and get back to baseline. And some things that are very important that you've probably heard over and over and over again are sleeping well, having a healthy diet, and practicing physical activity. And the reason you hear those things over and over again is because it's so true. It's easier said than done, but those things help, like gasoline helps a car to run. A good night's sleep, good food, and well-toned levels help our bodies to function properly. Likewise, we need to be able to center ourselves, and people do this differently. It may be through breathing exercises, yoga, meditation, prayer, mindfulness. There's all different journaling. There's all different paths that people use to reflect, to self-reflect, and to become centered again. So you know what will work best for yourself, but try to practice those different things, whatever works best for you to take care of yourself. It's also important to find a circle or circles of support. You may need one in work with your colleagues, you may need one outside of work with your friends, or another one with your family, but it's important to get people, surround ourselves with people who can help us and support us. But it's equally important to realize the time that you or someone else is having a problem that exceeds the capacity of friends or family to take care of. So if it's a serious problem and it needs professional help, we shouldn't hesitate to do that when necessary. So now we're going to transition to talking about a few examples, and we'll talk and apply some of the principles that we've learned from Drs. Takagishi and Aronson. So if you have a piece of paper and a pencil, go ahead and grab it. You can jot down your thoughts. So the first example is Daniel, and he's a real cutie, isn't he? A 4-year-old who had a grandparent who died recently from COVID-19. He's now showing fearful and clinging behaviors. What can you do to help him? So take a minute to think about that, and then we will share with you some of our thoughts about Daniel's example. So it's important to help children understand and name their emotions. So we can help Daniel to understand whether he's sad, or whether he's frightened, or whether he's angry. And that way we teach children what the different emotions are and put a name to them. I think it's equally important to teach the difference between experience and emotion and acting on emotion. So we know it's, Dr. Aronson had mentioned before, you might feel angry, and it's okay to feel angry in a situation. It's not okay to hit somebody because you're feeling angry. And that is not an obvious distinction, and that's something that we need to help children understand the difference. We also need to help them express their needs. So what does Daniel need right now? Does he need some quiet time? Does he need just to be read a story one-on-one? Does he need to talk? Does he just need reassurance? And so the more that we can give him the words to help him express his needs, the better we can help him. Now, we've talked about the challenges of creating stability, and children thrive on stability. And we need to do our best to create as much as possible within this hurricane that is COVID-19. It seems like things are changing all the time, and stability is difficult to create. But we need to do the best that we can to create as much stability as possible. Likewise, creating quiet space may be difficult. So Dr. Aronson talked about rearranging furniture, and with physical distancing, I don't know if some of the quiet space that perhaps was there before has had to be repurposed, but do the best that you can to continue to have a quiet space where children can go when they need a little bit of quiet time. And then it's also important to reinforce the behaviors that we want to see. Now, Daniel is not exhibiting any challenging behavior. We haven't heard that he's done anything that we would consider difficult, but maybe he was having trouble playing. And if one day you see that he's feeling better and he is playing again, you can say, oh, it's so nice to see you playing again. And that lets him know that we are noticing his emotions. And just remember Dr. Takakishi's acronym that she used before. Remember that rope that was frayed at the end? So that F is fear and feeling, having fits. So it's important to use those acronyms and think about different ways that we can help support children in understanding their emotions. All right, next part with Daniel. Later, Daniel tells his teacher that he's afraid that he will die too. What can you say or do that will help him? So take a minute to think about that. Perhaps you have a resource that you like to use. One of the first things is to gather yourself. I mean, I would be taken aback if a little child said that to me. So sometimes you need to just take a deep breath and then reassure him and state that you're so glad that he shared that concern. And tell him about all the things that the school is doing to help keep him safe. And then check in with him periodically later to see how he's doing and to see how he's processing the things that you've said to him. And then debrief with others, especially if that question brought up emotions in yourself. So maybe you need to talk to your other colleagues and discuss it. And then, of course, debrief with his parents or caregivers and offer them resources to help Daniel. Now, 2 resources that we're going to list, we'll have 3 slides of resources at the end of this presentation, but the American Academy of Pediatrics has something called healthychildren.org. That's one word, healthychildren.org. And they've got 2 great pieces, one on how children understand death and what you should say, and the other one on childhood grief and when to seek additional help. And those are both really nice resources that I found very useful. All right, on to our next example, family challenges. Sophia is a 3-year-old, and her mother recently lost her job due to COVID-19. You have noticed that Sophia's mother is tearful and distracted, and Sophia is now more withdrawn. What can you do to help her? So take a minute to organize your thoughts. What would you do in this situation? Well, I think one of the things that's really important is to know what your mental health resources are in your area. So if you have a behavioral health consultant available to your program, they can be really, really helpful. And in the resources at the end, we're going to talk about, we'll list different things that you could do to try to find out if behavioral health consultation is available. But they can come into the program or talk to you and suggest ways to deal with this. For the parents and the families, community mental health resources are important, and you can find out more about them by 211, or perhaps you've got a resource person within your program that knows those resources. You can find out if perhaps Sophia's mother needs individual counseling or family counseling, but if they're doing counseling with the children, if it's helpful if they're using evidence-based therapies like PCIT or cognitive behavioral therapy. Pediatricians and other health care providers could be great resources for mental health availability, and home visitation. If Sophia's family was involved with home visitation, a lot of times they have a wealth of resources available to them. Perhaps Sophia's mother needs more physical resources like food or housing or transportation. So knowing what those resources are in your area can be helpful. And we always want to try to coordinate so we don't duplicate our efforts. Our third example is Chris. He's a 4-year-old. He looks a little younger than that there, but he's a 4-year-old who just returned to school after his family experienced a rough time. And when his mom dropped him off, she just said, well, he hasn't been here for a while because we were going through a rough time, and she didn't want to seem to talk about it more. But now he's back in the program. He's refusing to wash his hands or wear a mask, and he's been pushing other children. So we know now that pushing has never been a good thing because it was, physically violent and hurts feelings when it happens. But now we have the extra level of it could possibly transmit infection. So what can we do to help Chris? Well, we might, for the whole family, start the day with extra reminders about how it's important to respect personal space. Like Dr. Aronson said, it's important to catch him being good. So increased attention, 5 times an hour when he's not acting out. See if you can have one-on-one talking time, if possible, to help him explore and name his emotions and maybe find out a little bit more about what's been bothering him. Increasing visual cues we talked about before to new behaviors that we expect, like wearing masks and hand washing. Chris has been away for a while, so maybe he needs some extra visual clues about what the expected behaviors are now. And then decide on the most important rules, especially the top 2, and make them very clear and reinforce them. As much as possible, we want to encourage Chris to be involved in talking about that. So we can talk about what the problems have been. We notice you haven't been washing your hands. What can we do to help remind you to wash your hands? And maybe if he does successfully begin to wash his hands, he can explain to other children or other staff members what he did to help him achieve that, and that helps him build a sense of mastery. All of this sounds easy when we say it. We know it's much harder when you're doing it in practice, so we'll need to all draw on our patience as routines are reestablished and we're developing, new methods for figuring out how to navigate through these difficult times. So this can include expressing your own challenges, like, oh, I'm finding my mask is fogging up my glasses. And I think I'm going to try to do that by try to fix it by putting a piece of tape on it. And so talking out loud about how you're problem solving can teach children how to do that. I think it's also important to continue to reach out to Chris's family to provide resources and support. And maybe his mother didn't want to talk about it in the beginning, but over time she might come to a place where she's finding it easier to express the kind of help that she could use. So I'm going to turn this over to my colleagues. We're each going to summarize the top 2 points for our wrap up, and then we'll have some resources and we'll answer some questions.
Well, thank you, Dr. Donahue. I appreciate it, and Dr. Aronson. The first point I want to make is that trauma can manifest in many ways for children, as we mentioned the acronym of FRAID, and it can be triggered by events such as the COVID epidemic and its effects on children and their caregivers as well. And if we use a trauma-informed perspective, we can help children build resistance and help our families and our caregivers all decrease the amount of trauma that they have witnessed. Dr. Aronson?
Yeah, well, I think when we've really reinforced here, which, reinforcement is good for us as well as for children when we're trying to convey information to them. And what we've said is that COVID-19 is traumatic in and of its own self. And we need to use the fact of the trauma boost behavior changes to solve the problems, apply appropriate tools to the situation, and be patient. Now, if it's not going well, then look at why it's not going well. And there, again, you always have the opportunity to turn to local sources of consultation. And sometimes it's way over something you can manage, but you can at least send the problem in the right direction to try to get it resolved. Using effective tools and early education settings is sometimes a whole family benefit that really, because the children are young, people in the family and in the program are to accept advice about how to manage it than if it touches off a barrage of self-defense discussion about why, who's to blame for the continuing problem. So we have to recognize that trauma is caused by COVID-19. There's no question about that. I think we won't find a person who hasn't, who would disagree with that. And then the question is really more about how to use the tools that have been shown to be effective, and to be patient with the approach that seems to be appropriate and to work.
And we can encourage resilience in children by providing safe and nurturing relationships, creating stable environments, building the children's capacity for self-regulation, helping children to know and name their emotions, and helping children to respond to their emotions in healthy ways. We need to take care of ourselves, and that includes building self-awareness through things like meditation, journaling, whatever, practicing healthy habits, sleep, eating, exercise, and creating circles of support to support us. We have a number of resources. These will all be available to use. Some of these are more Florida specific, some are national, some have to do with the American Academy of Pediatrics, and some are external. All right. I think we'll now turn it over to questions.
Hi, I will be facilitating the questions today. If you have any questions, please use the chat box to submit your questions. I'm going to start with the first one for Dr. Aronson. Can you please provide some additional information on how you might explain physical distancing to a toddler?
Oh, well, I think it's a wonderful opportunity to combine the visual image with the reality object. So, for example, I can take a lesson from the stores that are putting down footprints and taped on reminder about what the distance should be and how to recognize that distance and what direction to go. So I think we really have an opportunity to look around to see how other people are successfully presenting the challenge, and pick off the things that seem worthwhile to implement.
Thank you. I have another question. This one is for Dr. Donahue. How can you best support children with special health care needs, especially those that might be nonverbal?
Yes, that's a tough one. And this is difficult dealing with trauma-informed care in the COVID era to begin with. And then when you add a special health care need on top of it, it really does become very, very complex. I thought about this a lot, and we developed a book through the AAP. Full disclosure, I got no royalties for it, but we know that in childcare, a number of different children with different health care needs are being cared for, and people need help. So I think it depends a lot on exactly what the child's needs, special needs are. So a child with autism is going to have very different needs than a child with diabetes, and who's going to have very different needs than a child with visual impairment. So it's important to reach out to healthcare professionals to find out more information. That child healthcare provider may be able to provide information, or a child care health consultant if you have one available. There are oftentimes nurses who have special training in child care, and they can provide great information and ideas. For a nonverbal child, I think the principles that we talked about are all good, but they just need to be even more so. So we know children need simple instructions, and nonverbal children need them even to be more simple. Increasing visual cues instead of verbal cues is helpful to children who have more trouble processing verbal commands. Consistency and stability are super important, especially in conditions like autism. Children with autism really do like their routines and can be really triggered by changes in their routines. We need extra reinforcement for the desired behaviors, and just build in extra time into the day, because it may take a little bit longer to go through certain things like transitioning to different spaces than it had before. So I think nonverbal children and children with developmental challenges are a huge portion of the children with special health care needs, but another huge population is children with asthma. And we have, for a while, been trying to transition towards using meter-dose inhalers, which are the little puffers with a spacer, which is a plastic tube that you attach the inhaler, the meter-dose inhaler to, and using a face mask. Some children can put it directly in their mouth, but most children will need to, younger children will need to use a face mask. And that is a good way to deliver medication. We're still trying to learn about nebulizers, but we do know that meter-dose inhalers with spacers are preferable even before the COVID era. And so as much as possible, we can try to use those. I think it's also important to realize that any child, well, children with respiratory distress shouldn't be coming to child care, but if they develop it while they're at child care, it's important to give them medication and call an ambulance, but don't withhold medication just because of these concerns. Any child with respiratory distress needs to get their medication. So those are some considerations for some of the more common conditions that children with special health care needs have.
Dr. Donahue, there were two comments that are directly related for wearing masks for those either children who have autism who may have difficulty, as well as those that have asthma. Can you comment?
Yeah. Those are good questions, and I think the American Academy of Pediatrics and the CDC has realized that this is really tough. Adults are finding it difficult to wear masks, and I think we all realize that children are going to find it even more difficult. So you just do the best that you can. And if the child is just not able to do it, then you just try to practice social distancing and increase hand washing and some of the other factors, and to reduce the spread of infection.
Thank you. I have another question. This is for Dr. Takagishi. How can we provide some additional support to children as they're adjusting back to school routines?
Sure. It's also going to be very difficult for children as well as staff and parents to get used to going back to school. Some of them have been out for several months. So it's important to relearn the routines that we had had before. So some of the things were mentioned during the slide presentation as well, making pickup and drop-off as consistent as possible with the same providers, putting lots of extra cues into the room, so visual cues, verbal cues, reminding children at the beginning of the day what the expectations are, and having them be participants in learning and relearning all these rules, and making it fun to be back in school. But some of the children are going to have difficulty also transitioning back to all these new providers again. Some of them, I hate to say, may have forgotten some of the providers if they're very young. So making it fun to be back and back with their friends will help them want to relearn their routine.
Dr. Aronson, is there anything you wanted to add to that as well?
I think it is important to assess each situation individually. What are we asking of these children? When we're talking about they're going back to school, the school may have some new requirements that have to be navigated. And it differs from one place to another. And in some places, there are people who are making choices that may not make sense to others who have been their friends. So, for example, there are those who are doing the virtual learning and staying at home, and others who are coming back into the classroom, and they may have been peers, and they are peers. But the difference is something that we're going to have to explain, that it's okay that people are doing things differently. We also have to adjust to the changed circumstances of the families. Some of these families have gone without a paycheck for months, or for quite a long time, and they're working off of new resources that may not be available once they get back to any kind of work situation. So each of these situations really needs to be carefully heard. What it is that's going on, how are you handling the situation in your own home? It's also, the other thing is that there's a lot of increased trauma within the household, and sometimes that just really has to be addressed by a mental health resource, because it's just beyond what a child care professional can really handle. But it can be made clear that to take care of the behavior is a symptom. When the children are having challenging behaviors, it may be necessary to take it on as a partner problem. There's been an increase in violence, in family violence, so it may exceed what a child care staff person feels comfortable dealing with. But then there's some of that can be looked at as potential child care abuse and neglect, and by making the referral through the child care reporting system, then you might be able to launch some help. On the other hand, in some communities, that help is just not there, and sometimes it's to be some religious organization that will connect people with help. But each situation really needs to have some timely, thoughtful reasoning, and that may be very hard to arrange with all the things that are going on in reopening these educational facilities.
Thank you. I have two somewhat related questions. I believe this would be appropriate for you as well, Dr. Aronson. How can we encourage social distancing in the toddler classroom during center time or transitions?
Again,
and then related to that is how can, the other half of it is how can we support, the other half of the question is how can we support positive peer interactions while staying 6 feet apart?
Well, positive peer interaction, it doesn't mean that you take the masks off the children. You might want to have a game that involves the peers in working together to see how well they can put their masks on or keep their masks on. But the thing that you described, I think about in terms of the social distancing, the best tools that I'm aware of are the arm stretch, which I mentioned, and putting foot marks, pieces of tape about where children should line up for going outside. That gives a better visual reminder about what the distance for physical separation should be.
Did either of the other two presenters want to add anything on that really related to those two questions?
Yeah, this is Dr. Donahue. I think you make a game of it, like, have different lengths of ribbon and have kids guess how long the ribbon is, and that helps them with their visual capabilities. So that might be a fun game to do.
Thank you. I have two more questions. If there's additional questions that people have, please type them in the chat box. And this question is, I'm going to ask Dr. Donahue to again review a little bit and provide some additional information on how to support parents and children who may have lost a family member.
Yes, in those resource slides, I have the information on healthychildren.org, and there's actually a few more. We pulled those two out, but there's other links on there to further information that might be helpful. But I think on a more global level, it's important to listen and to practice active listening, which is listening to hear and not listening to speak. So I think just let parents and children talk about what they're feeling and just acknowledge those feelings. And that's more important oftentimes than the words that we speak. And also remember that children will, quote unquote, speak frequently through their play. So they may not have a conversation with you about something, but you'll see what's on their minds. They show what's on their minds through how they're playing. And so listen, practice the active listening there about what the children are trying to say through their playing. I think it's also helpful to talk to families about words that they're using if they've had a family member that has died. So that way we don't confuse the children with the vocabulary. We all have expressions that we like to use for death. Some people will say, the person died. Some people will say they passed away. Sometimes with children, you would say that they went to heaven. Whatever words that the family is using, it's important to understand what they're saying, and that way we don't confuse children with different vocabulary. So those are just some thoughts about dealing with loss, because unfortunately we've lost a number of people through this epidemic.
And I think there's been another idea that has been raised, is that one of the things that's good about healthychildren.org, those wonderful articles about common situations is many of them are, I think they're all actually available in Spanish, and they're not only available in printed form, but there also is a microphone reader that from the website of healthychildren.org, they can someone who is not literate, doesn't use the written word as comfortably as the heard word, can use that function of healthychildren.org.
Thank you. Yeah, those are important things. A number of these resources are available in Spanish.
All right, I have one last question. Thank you very much so far for all the questions that people have submitted. We have the last question that I have received is how much should you try to explain about COVID-19 and related issues, especially like not seeing relatives when to these young children? Dr. Aronson, do you want to start with that, and then maybe the other two could add in as needed?
I think one of the things we have to remember is that children reflect our behavior. So when you're explaining to a child, you can say, we don't see the Aunt Lucy and Uncle Bob because there's a possibility that we might be getting sick, and it's something we have to watch for. But you just do it as simply as you can and straight up. As there's no need to pussyfoot around the fact that there's grief. It's appropriate to say, we're feeling sad about not being able to spend time with so and so, and that may be because the person has died, and it may be that the child is not able to understand more than that we don't have our time together.
Hey, this is Dr. Takagishi. I would add also, as we're speaking, it obviously needs to be very short sentences that children can understand, but sometimes making it also into something very concrete for a child that they can do. For example, they could make a card or paint a picture that they could also share with their loved ones that they may not be able to be around.
Thank you.
I think that's important too. And in the process of making their card, they might be expressing some emotions through the pictures that they're drawing, and you can use that as an opportunity to talk with them about their feelings.
Thank you, everyone.
The other thing I wanted to, this is Dr. Aronson, the other thing I would urge everyone to do is to get in touch with your own feelings, because the idea is really to allow the expression of feeling to be welcomed from the child in that discussion. So you don't want to overdo it to make a 4-year-old your therapist, but at the same time, you certainly can use it as an opportunity to articulate some of that, the reaction that you're having.
Wonderful. Well, we are at the end of our webinar session. I want to thank Dr. Takagishi, Dr. Aronson, and Dr. Donahue for this presentation. I hope the presenters were able to answer all your questions. If you have any additional questions, you can see the slide is still up there. Please contact Wanda Minnick, the Executive Director of the Florida Head Start Association. Her email is on that slide, and it is wanda@flheadstart.org. At the end of this webinar, you'll receive a link to our evaluation survey. We do ask you to please take a few minutes to complete it. And through that survey, you will also have access to download a handout of the PowerPoint presentation today, as well as a certificate of attendance. Thank you all for a wonderful afternoon, and I appreciate you all participating today.
Be safe and healthy.
Thank you all.
Thank you.
Yeah. Yes. Stay well. Thank you.